Okay, we're going to talk about treatment for dementia, and it is a very challenging process for anybody who's taking care of somebody who has a developmental disability. All levels of caregivers are going to be challenged by a dementing process. So it's important to note that symptoms of dementia appear with this population exactly as it does in the general population. You're not going to see anything different. You're going to see exactly the same symptoms presenting in exactly the same way. It has medical implications because people who have developmental disabilities have higher physiological risks. So you're going to have somebody with hypertension and they're at higher risk for a dementing process. So you're going to watch that person a little bit more closely for these cognitive processes being degraded. There'll be even poorer cognitive functioning with this population because they're already cognitively challenged in whatever way they have, whether it's socially or intellectually, whatever they have, it's probably going to get a little worse. The degradation of cognition has to be incorporated into their treatment program, otherwise you're going to be frustrating that individual. They're going to have a very unhappy time. Their quality of life is going to be greatly decreased if you don't change the expectations that are going on with this individual. So given the people who have developmental disabilities and they're geriatric, if they have a significant cognition problem, depression will impact further on the cognition, and that is not so easy to differentiate. So just to review what we've talked about thus far, depressive impacts on cognition are not easily differentiated. That is something we really need to do a good clinical interview on. You need to know the difference between depression, cognition effects, and know the impact of dementia on cognition. And those two things are really not easy. Okay, let me back up a little bit. So, let's see. Did I lose it at the break?
Yeah.
Okay. So, treatment for dementia poses a challenge for anybody who's taking care of someone who has a developmental disability because it doesn't matter whether it's a family member or a professional staff member, it doesn't make a difference. It's going to be a challenge, and you need to have some support and guidance and treatment around that. And it's important to note that symptoms of dementia appear in this population exactly as they do in the general population. There's no difference. Dementia is dementia. Something to keep in mind, though, is that somebody who has a developmental disability is likely going to have hypertension, and so they're going to be at higher risk for dementia. So you need to do something about that. You need to track that individual a little bit more closely. And there's going to be an even greater cognitive functioning hit with this population. So whatever cognitive functioning level they were at, it's going to be a little bit more remarkably worse if they have a dementing process going on. And the degradation of the cognitions has to be incorporated into their treatment program so that you don't have a lot of frustrating experiences with an unrealistic treatment program that is not acknowledging the dementing process. You're going to be frustrated, they're going to be frustrated, it's not going to work. So given that people who have developmental disabilities and in the geriatric age range have these significant cognitive problems, depression impacting further on cognition is not easy to differentiate. So there has to be a certain set of very clinical, acute clinical skills that get called into play to be able to pull the thread on, is it dementia? Is it their developmental disability in some way that hadn't been recognized before, or is it depression? Or is it all of them? So the memory deficits that you're trying to sort out, is it dementia or is it depression, is to take a look at whether the I don't remember stuff is overemphasized. These people who are depressed usually don't have the energy to be involved in remembering things. So they don't have any problem saying, I don't know, I don't remember. And so if there's an overemphasis on not being able to remember, it's more likely depression than dementia. Because what happens with people who have dementia is that they're either oblivious to the deficit or they will minimize it in their mind. They just think it's because of stress or something like that. Or you take a look and see if their orientation to person, place, time, and purpose, the 4 spheres of orientation, whether it's affected or not. With dementia, it can be affected, but with depression, not so much. People who are depressed know who they are, and they know where they are. They might not have a date and time, they might not be tracking that very well, but they know when they're supposed to go to the bathroom and they know when they're supposed to be eating, even if they don't want to eat. But somebody who has dementia might not understand that. They don't pull up the cues from their environment and interpret them very well. You check and see whether language has deteriorated or not. It doesn't get deteriorated with depression. They might not want to talk as much, but that's more of an emotional expression of where they're at than having a cognitive deficit. People who have dementia usually can't talk as much, or they're afraid to talk because they don't really understand what's being said to them. They have that receptive aphasia piece. So take a look at their language. And then the apraxia. Are they being able to use routine movements competently? Are they at baseline with how they're moving through the world and how they're using tools, or not? Somebody who's depressed is going to know what a pen is for. They're going to be able to walk at their usual pace. They might be walking slowly at their usual pace, but they're not going to be walking into walls. They're not going to be tripping over chairs and things like that. But somebody who has apraxia will. The negativity is an interesting feature. Negativity is a symptom of depression. If the person has always been negative, if they've always been somewhat of a pessimistic person, oh, that's not going to work out very well, then the negativity doesn't count as a symptom. It's the change that we're looking at. And dementia doesn't usually make somebody negative. It can make them suspicious, but not necessarily negative. So if they lean towards suspiciousness, it's probably dementia. And if they lean towards negativity, it's probably depression. You need other features to be pulled into play. So the treatment and the interventions we would do with somebody who has developmental disabilities and they're in the geriatric age range is to take a look at their behavior, because everybody responds very well to praise and rewards and verbal interactions. And consumers of services that we provide are responsive to verbal interventions. That's not something that we're going to have to throw away. So let's talk about some treatment advances. There have been quite a few, not enough in my view, but there have been quite a few treatment advances. There's acetylcholinesterase inhibitors. Sometimes people take the acetyl off and they just call it cholinesterase inhibitors. And there's glutamate-targeted compound. There's just one right now. There's a rivastigmine patch for people who have some dysphagia. They don't have an easy time swallowing, so you can wear a patch. That's fairly new. And the donepezil oral disintegrating tablet. This is for people, they might have some trouble swallowing, but they also might have some issues with meds in general, and they either cheek and spit, or they just spit the med right out. But with the donepezil, you put it under their tongue, and it gradually disintegrates. I mean, it doesn't take 20 minutes. It takes several seconds. And that's a big boon for us, because the mechanism of these medications being absorbed into the system is important to keep in mind. So if you can get it into them, it's more likely to work. So these are the general classes of medications we use for dementia. Alzheimer's type is acetylcholinesterase inhibitors, also called cholinesterase inhibitors. We use atypical antipsychotics. Those are the newer ones. So Clozaril was the first atypical, then Risperdal, Zyprexa, Seroquel, Giordana, Abilify, etc. Most of the time we don't use Clozaril because of the blood draws that are required, but it would be very good for this. The atypical antipsychotics help clarify thinking, and they help to organize the person's thoughts in more comfortable ways. It also has some mood stabilization features to them, so if they're irritable, or if they're agitated, or they're acting out, these antipsychotics can be very helpful in that regard. And then certain anti-epileptic drugs, more the mood stabilizers and more valproate, which is Depakote. Though that has been particularly helpful for people, especially if there's been aggression. Valproic acid has been very helpful for people who have aggression as a result of dementing processes with people who have developmental disabilities. So acetylcholinesterase inhibitors they're helpful. They reversibly inhibit an enzyme. So, for example, imagine this. You have an enzyme. Enzymes, their job is to clean things up. And this particular enzyme's names end in ASE. So if you see ASE, that's an enzyme and its job is to clean. So this acetylcholinesterase, it's an enzyme, and its job is to clean up the buildup of choline, acetylcholine or choline. And choline's job is to help with thinking, help with memory. But you can't have old, stale choline laying around in the brain. And so the enzyme comes through and it cleans it up. And then your body makes new choline. And it gets old and stale, and the esterase, the cholinesterase, comes along and it cleans it. So what they determined is that choline, it affects memory. The more choline you have on board, the better you're going to be able to think. So the idea was, when this medication was first proposed, was let's take the enzyme that cleans up the choline and make it less active, so that there's a little bit more choline around. It might be a little stale, but it still has some purpose. So if you have this enzyme that's inhibited from cleaning up the choline, then maybe we can enhance the memory. And the research showed that it does. It doesn't repair it. It doesn't make it all better, but it helps the person retain some of their memory processes, and it decreases some of the degradation of the memory, because you're just dealing with one particular neurotransmitter, the choline. So if you inhibit the enzyme that's supposed to clean it up in the central nervous system, it allows the buildup of acetylcholine in the brain, and it temporarily improves your cognitive functioning. You're able to think a little bit better. You're able to do some problem solving. These are the acetylcholinesterase inhibitor agents. Aricept, Remenil, Cognex, Exelon, those are the trade names. The common side effects of all of them are GI upset. That's the #1 problem. Nausea, vomiting, diarrhea, stomach pain. So they just don't feel very comfortable with their GI tract. Something to pay attention to. Also, it has a little bit of an anticholinergic feature to it, so it can give them headaches and make them feel dizzy. And one of the things to keep in mind is that even though it does help with some of the physical issues about what's going on, it's very helpful in memory things, it can unmask a cardiac conduction problem. Because you know our hearts are mechanical, bump, 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 but they're also electrical. There's an electrical system, it's called the Purkinje system, and it tells the heart muscles when to pump, when to fire. And when you take acetylcholinesterase inhibitors, you are inhibiting this particular enzyme from cleaning up the acetylcholine. And what happens is that there might be a problem with the way the heart is electrically functioning, and you have just unmasked it. So you might find this cardiac problem that you didn't know previously existed. Originally, people were thinking, oh, that's a bad side effect of this medication. It causes these cardiac problems. But what it's really doing is unmasking it, because some of the problem that's going on with the choline in the body is not showing you what's happening with this heart problem. And when you address that choline level, it shows up. And so you have to take care of that. You have to address that cardiac problem. You have to watch your liver enzymes, especially the ALT. So they need to have their blood drawn. And it can interact with other medications because it's inhibiting a particular enzyme, which kind of indicates that it might inhibit other enzymes. So that's when your pharmacist can be very helpful in indicating to you how these medications interact. And if it's going to be suppressing the removal of other medications from the system, then you're going to see toxic effects build up in the body. So you have to watch what else they're on. So we've talked about all these medications that you can give. None of them cure a dementing process. Unfortunately, that doesn't happen. We don't have a drug for that. Although they are having some interesting studies going on now with the concept of plaque formation and like I said before, the Golgi structure fragmentation, but we're years away from that. So for the time being, what if the drug therapy doesn't work? What if their GI symptoms are too extreme? What if it's just too expensive? The acetylcholinesterase inhibitors, they cost a lot. And what if they just can't afford it, or their plan doesn't cover it, or nobody covers it? You can change drugs. There's a 50-50 chance that another medication will reduce the symptoms. So if drug A doesn't work, let's try drug B. If drug B doesn't work, let's try drug C. You've got 4 or more drugs that you can try. So that's a good option because they all do it from a slightly different direction. Sometimes the drug fails because there's side effects that the person is not able to tolerate, or it doesn't mix well with the side effects of other medications. So if you switch to another medication, you might be able to get away from that particular set of side effects because everybody metabolizes things a little bit differently. Check the environmental factors. Even though we're looking at dementing processes, it's a disease process and it will proceed, you can make things better with checking your environment. And it's an easy fix. You don't have to add a drug. You don't have to worry about side effects. If you check your environmental factors, the pharmacology becomes a little less dire. So people with dementia not respond well to low light. And this has been a problem in a lot of group homes and in residences because people get very agitated when they're demented, and so they'll try to lower the lights to decrease the stimulation, which is what you would do with somebody who is bipolar. But when you lower the lights, when people have dementia, that increases the shadows, and now they can't differentiate what's going on. So they're going to misinterpret, and they're going to be very frightened and probably paranoid, and so you need to keep the lights up on them so that there are as few shadows as possible. Keep the ambient noise to a minimum. So if you have noise that tends to like slam around and it gets very noisy, especially with tile floors and hard surfaces, there might need to be some detection of decibels and get it lower. And you don't want to have a lot of noise going on. And behavioral treatment. Behavioral treatment always must accompany pharmaceutical care. You can't just depend on drugs. Drugs are an approximation of a normal, healthy, functioning body. And it's an approximation. We're very seldom going to hit it right on. So just to talk about cholinesterase inhibitors and anticholinergics. Anticholinergics would do things like cogentin or artane, and any medication that dries them up. So anything that has an anticholinergic side effect, like a lot of psychiatric medications. People who are developmentally disabled and they're geriatric, when they're given a cholinesterase inhibitor for dementia, and they're also given like an anticholinergic to dry them up because they have a urinary incontinence. So they're given something like, you know, that'll just absolutely, like ditropan, dry them up. You will see about 50% faster decline in functioning than those taking just the dementia medications. And what I'm seeing in the literature and what I'm talking about with my colleagues is that in effect those medications cancel each other out. Don't do it. So that's it for dementia. Let's talk about menopause. Hormonal changes begin as young as 30 years old in people who have developmental disabilities. The hormonal changes with both males and females, but it's really remarkable with females. They can have perimenopause or menopause at 30, and medications can influence the early onset of perimenopause or menopause, and medical conditions further influence these hormonal milestones. Not necessarily if they've had surgery, of course, if they've had hormone change due to an extraction of their ovaries, but in general it can propel people into a menopausal state much more early than you would expect. And people who have Down syndrome are much more likely to have earlier onset. I very frequently see it in the 30s. Not so much in the 50s. By the 50s, anybody with a Down syndrome is probably already in menopause or perimenopause. Some women who have different developmental disabilities, they might not say, you know, how they're feeling, and if something gradually comes on, they just adapt, and which is a good thing. That says that they've been very productive in their treatment, but it could be something that could be missed, and we need to track it for physiologic as well as quality of life issues. So the symptom of hormonal changes, and you need to track these fairly early, is the short-term memory decrement. And that's something that you will have to detect. Is this a hormonal change in this individual, or am I seeing a dementing process? So you have to put it all together. Short-term memory decrement can be from stress, it can be from hormone changes, it can be from dementia, and we have to figure out what's what. There's hot flashes. Of course, people know what hot flashes are. Some people have hot flashes that arise and it'll move up their body and they feel it coming, you know, like they'll feel very warm in the middle on their core, and then their face and their head will get very, very hot and they're like, this is really uncomfortable. Or sometimes people just get hot flashes in certain parts of their body and it doesn't progress. There's also warm flashes, which are much more comfortable for people to manage, and frequently they don't even complain about it. But there's something unusual that a number of people I've consulted for have found. They have cold flashes where they're all of a sudden feeling very cold and uncomfortable and they just can't get warm. And it's not the chills of having a fever, it's this uncomfortable kind of feeling. And it's a cold flash, it's just a different way of expressing those hormonal changes. Vulvodynia. Vulvodynia is a very interesting process, not fun. It is the pain that will occur in the woman's vagina because of the tissue drying, and the pain can take a number of different forms. The most common one is just plain dryness where it's a little itchy. The next most common is pain that feels like 1,000 paper cuts. It's immediate, it doesn't have a gradual onset, and all of a sudden they have this very extraordinary pain. And what I found interesting when I have run into people with vulvodynia with this particular definition is if they have any dementing process going on, they're already a little suspicious. They're going to think that somebody did something to them because it happened so abruptly. And there's a lot of things that we can do about vulvodynia. We can do general hormone replacement, which is not usually recommended for anybody, let alone this particular population. But there are many creams. There's a vaginal ring called an estring. It has a very low level of estrogen, and you just insert it and it stays in for 3 months about. Hirsutism, where you have hair growing where you didn't used to have hair growing, and the hair that you do have, that you're supposed to have, starts to thin out. So there's this flip of what's going on with your hair. There's changes in behavior. People are not as comfortable with certain things that they used to be comfortable with, or they change. And their sense of physical well-being changes. They feel mortal, they feel more at risk, they feel more uncomfortable in their body, they just can't get comfortable in certain positions. Sweating, especially with the hot flashes, and night sweats in particular, What can happen with night sweats, because this can happen gradually or it can happen in an accelerated fashion, is that somebody might have night sweats and they're drenched. And the assumption is that they were incontinent, that they had a urinary incontinence while they were sleeping. And people get really busy with that, and they're starting to give an anticholinergic to try to dry them up at bedtime. And that's it's something that has to be detected. And there's actually some pretty cool ways to check that out. But night sweats can be so voluminous that the sheets and the pillow and the blankets are all soaking wet. Sleep is usually disturbed, and it's disturbed in a couple of different ways. One is that if you're having hot flashes at night and you're having night sweats, then that's certainly going to wake you up. But the insomnia is also part of the hormone disorder. So the person is unable to sleep, or they're unable to sleep at a deep level, or they just wake up a number of times. There's heart palpitations. Hormones have a huge impact on everything that goes on in our bodies. And when the estrogen level drops, which is what happens with perimenopause and menopause, the heart conductivity has to adapt to that different level of hormone, and in the meantime there might be palpitations. The skin can become itchy, and if the person has already had, as frequently happens with people who have developmental disabilities, they have so many dermatologic problems, but the itchiness takes on a different feature, and it's uncomfortable. And it's simply because they don't have the estrogen that's changing the flexibility and the general plasticity of their skin. There's going to be backaches and joint pain, headaches, because, again, of the hormonal level, bloating and weight gain. The average weight gain in the general population at menopause and post-menopause is 1 pound a year. So if you have somebody who goes through menopause at 30, by the time they're 70, they've gained 40 pounds. I mean, that's unacceptable. It's too high of a weight gain. So you have to stay right on that. People who have developmental disabilities are more prone to weight gain because of their other medical problems and their gastrointestinal wiring. So they're going to be much more likely to gain weight. And the average weight gain per year is 3 pounds. For people who have developmental disabilities. And if they go into menopause in their 30s and they're living because of the fabulous care that we're giving them, we have, and I didn't mention this when we started, we have a group, a cohort of people with developmental disabilities who are geriatrics. This is the first time that's ever happened. People used to die very early from cardiac conditions and from their very complex medical conditions and their comorbidities. But their medical care, their behavioral care, and their quality of life issues have been so well addressed over the past couple of decades that we have this group of people who are geriatric and they have developmental disabilities, an entirely new specialty area. So I should have mentioned that to begin with, but fabulous work, everybody, because we actually have this new specialty area because of the good work you've been doing for so long. But the weight gain is going to be pretty remarkable because people are living longer, and if they're gaining that regular 2 to 3 pounds a year, it's a lot of extra weight, which can make their other comorbidities more problematic. Check irritable factors if you have access to their blood relatives. Good to know what their mother did. If there's surgical procedures or their mother died before they went into menopause, you might not know. Older siblings might be good to know. It has to be an older sibling because the developmental disability will propel them into menopause earlier than the general population, so a younger sibling would not have gone through it yet. So if you have blood relatives, that would be a good way to check out what are they most likely going to do. Like if their mother is alive and had a naturally occurring menopause, perimenopause, and menopause, and did not have hot flashes but had warm flashes, the chances are that your individual is going to have warm flashes. It just depends. So what do we do to intervene for the health of the individual, the quality of life issue? Well, there's support. There are things that you need to do with people who are in menopause and going through menopause that you don't need to do with the other crowd. Yeah, loose clothing is good. You don't want anything very restrictive, and especially because they're going to be having these episodes of all of a sudden they're going to be really hot. There are creams to deal with the estrogen level problems like the vulvodynia and the vaginal issues, and mnemonics to help with short-term memory loss. It's temporary. If you teach them how to memorize things, how to keep things in their mind, you put things in a particular place, that's where they belong, that's where they're going to be. It'll help the person be less distressed about the changes they're going through. Comfort measures, comfort interventions, topical medications, like creams and lotions, and then like the insert I mentioned before, fans are very helpful. Moving air, especially across the head, is very helpful for helping somebody get through a hot flash. Cooling substances, there are gels, there are pads, there are ice packs, there's a whole number of things that can be done to help somebody through a hot flash. There are medical interventions, and they're not as well recommended, and I don't recommend them quite so often for people who have developmental disabilities because they're such complex cases. But if you have somebody who's fairly straightforward, hormone replacement therapy can be considered if their other factors don't discourage it. Selective serotonin reuptake inhibitors. This is a class of medications in the United States that is Prozac, Paxil, Zoloft, Celexa, Lexapro, Vibrid. They're antidepressants, but a very low dose of Lexapro in particular. Although I have had colleagues tell me about the other SSRIs they've had success with, but for me it's been Lexapro, like 5 milligrams of Lexapro. Very helpful in managing the hot flashes. Doesn't make them disappear. It's not a hormonal replacement, but it can help to manage it. So it'll take them from 40 hot flashes a day down to like 6 or 7, something more manageable. Same thing with anxiolytics, anti-anxiety medications. Also something to be taken into account because you don't want to give somebody a benzodiazepine if you don't have to, like Ativan or Xanax. But an anxiolytic can be very helpful if somebody's distressed about this particular transition in life. And then there are supplements. Some people, few, but some people respond to soy, which is sometimes has some estrogen, phytoestrogen replacement. It's the plant version of estrogen. It's not the human or the mammal form of, a mammalian form of estrogen. And some people respond to it, like black cohosh tea and edamame and soybeans and soy, things like that. Not necessarily soy sauce, which is fermented, but you have some options. Some people respond to them, about 10% of people, so keep it in mind. So that's menopause. Now let's talk about the guys. Update on prostate health. In order to have a healthy prostate, you have to be well hydrated. And I hearken back to the conversation we had earlier about water. The best hydration comes from water. If you have other things in your water, you can put a little lemon juice, you can put a little lime juice in there, but basically if you put anything else in your water, it's not water anymore. And good hydration is really what helps the prostate work the best. If somebody has a urinary tract infection, the earlier you get on board with treating it, the better off the person's going to be. But also keep in mind that people who have developmental disabilities might respond to a lower level of colonization of the bacteria, a subclinical level, and you might want to treat just because you see symptoms, not because of the lab results. And nutrition. So let's talk about nutrition with prostate health. Again, if you have access to somebody who has a blood relative, an older male blood relative, it's good to know what's happening with their prostate. Did they have a lot of prostate infections? Did they have issues with prostate cancer? These are things to keep in mind. And also, just to be precise about the medical information, an enlarged prostate is not cancerous prostate. Those two things are not the same thing. So, nor does an enlarged prostate increase the chances of somebody getting a prostate cancer. You can have a particularly healthy, pink, glossy, beautifully sized prostate, and you can still get prostate cancer. So an enlargement does not increase your risk whatsoever. I assume it's pink and glossy. I've actually never seen one in action. So benign prostatic hypertrophy, BPH, benign because it's not cancer, prostatic because it's the prostate, and hypertrophy, which is the overgrowth of it. It happens with people, it raises this particular antigen in the blood 2 to 3 times normal. So that's why we have people have their blood drawn. So you get a PSA level, and it's the prosthetic specific antigen, PSA. And if you draw that and it's over 10, 11, some clinicians won't treat until it's over 11, then you have a prostate issue that needs to be addressed, and it could be diagnosed as prostate cancer. But just having BPH doesn't mean you're going to have cancer. High PSA levels, on the other hand, do indicate that you're at higher risk for cancer. It doesn't necessarily mean it's cancer yet, but it increases your risk, again, at a higher level. Nutrition, some people can use cranberry juice. That sometimes is healthy because of the acidity of the cranberry juice, which is pretty potent, much more than other acidic drinks that you can have. 4 to 6 ounces of cranberry juice a day can help with some individuals. Some individuals don't respond to that. In general, when they talk about prostatic health, a lot in the news about that lately, but what the research shows is that if you have a high calorie diet, and it doesn't matter whether the calories come from fat or fruit, or it doesn't matter, the more calories you have, the higher at risk you are for prostate hypertrophy. It's benign, it doesn't mean cancer, but it means that you're going to have some trouble with your prostate. It's going to be painful, you're going to have trouble going to the bathroom, you're going to be uncomfortable, it might even interfere with your sleep and your functioning. So lower calories, routinely in research, has been proven to be very helpful. Less protein is less demanding on the general area of your genitourinary system. So not having a huge steak, 3 to 4 ounces, the size of a deck of cards, should be what your protein level, what your consumption is in a meal. So no more than that. Less protein is better. Some people will have a peanut butter and jelly sandwich and they have a lot of peanut butter. Peanut butter is protein and it has a lot of calories in it. And you put 300 or 400 calories of peanut butter on a sandwich, which is, what, 4 or 5 tablespoons, that's a very heavy caloric and heavy protein snack that people might be having. That was more like a full meal. There are plant-based estrogens called isoflavones or flavonoids, which can be helpful in prostate health. Low-fat diet and no caffeine. No caffeine from coffee, tea, cola, chocolate. Can't have chocolate. Can't have coffee, tea, or cola because they have a fair amount of caffeine in it. The problem is that some medications have caffeine in it, especially medications to treat migraines. So you want to keep that in mind, that if somebody's having a lot of migraines, like a cluster headache problem, they are going to be taking medication that has caffeine in it for the most part, and you need to take extra care of that prostate during that period of time. So make sure they're very well hydrated, that their calorie count is a little lower, their protein count is a little lower, and less fat in their diet. Saw Palmetto is an interesting thing, as are, it's a type of a berry oil. It's been shown to reduce the rate of growth in the prostate gland itself, the overgrowth of it. But saw palmetto can be very uncomfortable gastrointestinally. This I have found to be a familial feature as well. So if you had a dad who was taking it, or an older brother, blood brother, who was taking saw palmetto for some reason, and they got a ton of gastric discomfort, or like gas and diarrhea, or just cramping, then it's likely this person is not going to respond well to saw palmetto. So just something to keep in mind. The diagnosis of prostate cancer with people who are geriatric and having developmental disabilities is often not made until late stage. And usually at late stage, it has metastasized, so it's moved to other areas. One of the most common areas it moves to is the bladder. Not a huge problem. It can be addressed. It's not the easiest to cure. Kidney cancer is easy to cure, but by the time it metastasizes to the kidney, it's probably already been to the bladder. But the problematic metastases is to the bone. Bone metastases are very painful. So you want to check and see if somebody's having a prostate problem, and their PSA level is what's going to give you the real indication. So you want to do their testing. You want to do their PSA levels on a yearly basis. And when it starts to creep up, if it's 1 or 2, no big deal. The next year it's 4 or 5, okay, we're going to check that. Let's try to increase their hydration, decrease their caloric loading, and we want to address it. By year 3, if it's up to 10 or 11, then they might be looking at options for treatment. The options for treatment are surgery, chemotherapy, radiation with seeds, where they implant the seeds, or radiation with targeted radiation, where you know, for 5 minutes, you just let them beam you with radiation. The follow-up for that involves looking at your continence issue, because whether you've had surgery or you've had radiation or the seeds, you're probably going to have some dribbling. It's not going to be a very tight seal anymore, and so there's going to be some continence issues. Not full incontinence, but there'll be some discomfort. And so you have to teach people about urinary tract infections, hygiene in general, washing their clothes. They might not smell what's going on, but others might be able to, and urine flow. So urine flow is usually staggered, so you'll go and then like 10, 15 minutes later you'll have to go again. So what people suggest is that you sit, that when you go to the bathroom, instead of going to the urinal, you sit, and then go back 15 minutes later and empty your bladder again. And that can decrease on some of the incontinence issues. With chemotherapy, I just wanted to mention some of the issues that can happen with chemotherapy, specifically with this population. I mean, of course, anybody can have these side effects, but it's tougher on people who have developmental disabilities because of the way they're built. So there's going to be gastrointestinal side effects. Any chemotherapy is going to give you gastrointestinal side effects. You can have anything from mouth sores to hemorrhoids to any ulcerations in between. But people who have developmental disabilities already have some GI problems. So it's more likely that's going to be #1 on the side effect list. There's going to be blood side effects. So you're going to have leukopenia. Leuco is white blood cells. Penia means it's a low amount. So they're going to have a low level of white blood cells. So they're not going to be able to fight infection very well. So they can't be hanging around with people who are sick because they're going to get really sick and they're not going to be able to fight it off. They might get anemic. Their red blood cell count might drop a little bit. And they might have thrombocytopenia. They might have thrombosis. They might have some clots that they're throwing around. That's a problem. So watch for strokes. Neurological side effects, asthenia, that needles and pins feeling, usually in the fingers and toes, very uncomfortable, like you're being poked. Renal side effects, renal failure, not an uncommon prostate cancer chemotherapy side effect. So to go back to the nutrition aspect, there are a lot of advertisements about very low-fat diets, like the Ornish diet, which is fruit and vegetables and grains, fat-free yogurt, fat-free milk, fat-free cheeses, and egg whites, no egg yolks. It's mounting evidence that this very low-fat diet, very low, like the Ornish diet, which is kind of extreme, really works. So, you know, I was always kind of equivocating about it, but the research is supporting that in the long run this is a very helpful low-fat, very low-fat diet, like Pritikin low. And then the vegetarian diet has some pretty good research results showing as well. So that's prostate health. Bone health. As people get older, everybody, as they get older, their bones start to become less vigorous in their production of their bone cells, and you can get osteopenia or osteoporosis. Certain medications will enhance that. So, for example, if you're taking an anti-epileptic drug, the chance that you're going to have some bone loss is pretty good. It's over 15%. And they have to take anti-epileptic drugs. It's not a choice. So what we have to do is pay attention to osteoporosis. Get that bone density checked. It's a very easy check. It's not intrusive in any way. There's two different kinds. One is you just take the heel of your foot and you put it in a machine, and it reads it like, you know, it just reads the reflection off of the bone surface, the hard surface. The other is to lay on a table similar to having an x-ray done, and it goes up and down your body and it checks your bone density. But it's good to check osteoporosis regularly because it can happen very abruptly. I had somebody who was taking gabapentin, which is an anti-epileptic drug, and she was taking it for epilepsy and for pain and from a motor vehicle accident, and she had her bone density checked every single year, and she was put on gabapentin right after she was had her bone density checked, and the next year at her annual physical, her bone density was down 13%. 12 months later, 13% bone loss. That's a significant bone loss, so you really have to check it regularly. Back and joint pain is what commonly happens when your bones are not strong enough to support the rest of your structure. Because remember, everything else you have, all your fat, all your organs, all your skin, that's all hanging on your bones. And if your bones are not strong enough to do it, they're going to crumble and things are going to start to hurt. You don't have as much flexibility. It's exhausting. You don't have the endurance, and you can't move like you used to if your bones are not in good shape. So maintaining your bone health involves good nutrition. You have to have a reasonable amount of calcium. You have to have a reasonable amount of activity. And by activity, I mean you need to have some weight-bearing activity, especially after menopause for women. And even if you go into menopause at 30, you have to start walking around with some weights. So one of the things I have people doing to increase their activity as well as their weight-bearing exercises is, let's say they're watching TV. Lots of commercials on TV. People usually have water, a bottle of water or something like that, and it's not a pound, but it's you know, it might have some weight to it. And if they just stand up during the commercial, you know how many commercials there are, and they just move this from hand to hand, that could be a very easy way of them having their activity and having a little bit of weight-bearing exercise. It's not onerous. It's not for, you know, even if people are immobile in some way or they have a lot of spasticity problems, they would be able to do something to increase. So the activity actually helps to build more bone. Monitor the side effects of long-term use of compounds that do decrease bone density, such as the anti-epileptics. And calcium supplements have to have vitamin D in them, otherwise the calcium won't be able to be metabolized. So if they just have calcium with no vitamin D, it's just a waste. That's bone health. Depression. Depression is called the common cold of mental illness because lots of people get depressed. People who have developmental disabilities are at higher risk for depression. And as people age and they have more problems with their bodies and with their functions, they might be even more at risk for depression. So the expression of a depressed state is somewhat different for people who have a developmental disability and they're a geriatric. They're very likely to complain of physical problems instead of sadness. So they'll complain of a headache, or they'll complain that they're achy, or they're sore, or they're not able to do things like they used to do, as opposed to saying the abstract term of I'm sad, or I feel empty, or blah. Those tend to be articulation levels that are less easily attained. Dementia is certainly a risk factor for people who have depression. Massive life transitions can trigger flare-ups of a comorbid psychiatric condition that can involve depressive symptoms, because you don't just get one psychiatric problem. You can get depressed with schizophrenia, with bipolar disorder, with an anxiety disorder, with post-traumatic stress disorder. Any psychiatric symptom can have layered on top of it the symptoms of depression. So if they have a major transition, like somebody has moved out of their house, or their house itself is closing and they have to find a new residence to live in, or things are in shift all over the country about what's happening with the treatment of people who have developmental disabilities, these transitions can trigger depressive symptoms, and we need to watch for them. Maintaining the mood with this population typically can involve pharmacotherapy. So what do? We can augment what's going on with their medication regimens with lithium. We can use a selective serotonin reuptake inhibitor. I mentioned those before. Prozac was the first one. Paxil, Zoloft, Lexapro, Celexa, Vibrid. Those are the ones in the United States. Maui's monoamine oxidase inhibitor. There's only 3 of them. Nardil, Parnate, and Marplan. Those are the 3 pills. There's also a patch. So if they have trouble swallowing, they can have an antidepressant patch. It's good to treat depression either with talk therapies, psychopharmacology, or both. You don't want to leave depression by itself. It does not go away on its own. It can involve psychotherapeutic interventions, watch their activity levels, try to include them. That's what's good about cognitive behavioral psychotherapies, is that if you move, if you do things, if your behavior is in a healthier realm, the possibility that your feelings will come along behind them and be healthier is very real. And all of the research on cognitive behavioral interventions are pointing in that direction. So you want to keep their activity levels up. You want to increase empathic support for what they're going through. It's a real thing. It's a real problem. Individual support and guidance, and of course monitor for lethality. And I don't know, do I say something? I don't. Alcohol. Alcohol is a depressant, and we're not going to do this today, but at some point we need to spend a lot of time talking about substance abuse with people who have developmental disabilities. It's a huge problem, and alcohol is a depressant, and a lot of people think that if they have alcohol, it'll make them feel better because people usually are gigglier, happier, and more interesting when they're drunk. So that's not exactly what's going on. They're disinhibited. Their inhibitions are being depressed, as well as some physiological functionings. So if people are depressed and they drink even a very small amount, like a hard iced tea or a hard cider or a beer once a week, those can propel a depression into a deeper level and makes the antidepressant ineffective. So something to watch out for is that they do not have any alcohol. Medical implications of depression are weight changes, up if they're eating too much, down if they're not eating enough, sleep disturbances, if they're sleeping way too much and waking up exhausted, or they're sleeping very, very little and they're exhausted. Passive self-harm. They stop eating, they stop taking their medication, they refuse to do the things that they need to do to stay healthy, like they have a spasticity problem and they're not doing their physical therapy. Medical implications of depression could include deconditioning. So now they're not able to do the things that they were previously able to do. They aren't in that mode anymore. There's less cooperation with needed medical treatment. They're pushing these things away. They just can't be bothered. Whatever problems are going on with their body, they won't heal as well. There's actually a slowed metabolic process that accompanies depression, and whatever needs healing processes is not going to happen as often. And their risk for a cardiac incident is very high. We talked earlier about the enmeshment of diabetes and cardiovascular disease, but what's been happening in the recent years is the research on depression and cardiovascular disease is fascinating. Some of the research really calls into question, is the cardiac event first and the depression follows, or the depression starts and the cardiac event follows, because they're so closely entwined. So that's something we're learning a lot about. Lower pain threshold, and so the person needs more analgesics. More analgesics mean more side effects. They probably will have more diagnostic tests because they're complaining about so much and we're trying to figure out what's going on. So they're just depressed. That's the only thing that's going on with them is a depression, but they're complaining about physical problems. It happens much more often with the developmentally disabled than with the general population. And so their physical complaints are going to cause any clinician to say, well, I better get this tested. So there's going to be more medical diagnostic tests, and they're going to have more frequent and more severe pain complaints. But we talk about that in the 3-module episode on pain and pain management that I do with my fabulous husband. Let's talk about rheumatoid arthritis in the last little bit of time we have here. Rheumatoid arthritis is a huge problem. You need exercise, weight loss, physical therapy to manage the symptoms, but they don't affect the cause. The disease will progress. It used to be, it's an autoimmune response in the synovial fluid. The synovial fluid lubricates some of the joints in our body, the synovial joints. It does affect the life expectancy. It'll drop the life expectancy by 5 to 10 years. And it used to be that we didn't treat until we had to. But now we know that aggressive therapy for rheumatoid arthritis early slows the joint destruction. So you might have seen on TV they have more commercials for treatment for RA, and that's because we know by research that we can interfere and maybe slow down the progression of joint destruction. Exercise for older people who have developmental disabilities can ameliorate a lot of problems. It reduces their falls because they're just more in tune with their body, and of course it's always going to be good for reducing cardiovascular disease. Their aerobic capacity, so you're going to be minimizing their respiratory risks. If you can get them to exercise, it increases their flexibility and their muscle strength. Their physical performance in general will go up, as will their confidence and their quality of life. Their sleep quality will be better because they're tired. They kind of discharge the energy, and whatever anxieties and stress they had really can be reduced greatly so that they sleep better. Their mood will be better. Exercise, movement and behaviors that are healthy, usually the mood will come along behind it and be healthier as well. And just a general sense of well-being is very important. So, had to go a little faster than anticipated because of our technical challenges. But this is the first of the 5 poll questions that we have. Question 1. Of the 90 to 95% of diabetics who have type 2 diabetes, what percentage best describes how many have control of the disease? Less than 80%, less than 20%, less than 50%, or it varies? The answers are right there, but the answer to this question is less than 50%. So anybody, whether they have a developmental disability or not, they have diabetes, type 2 diabetes, they're less than half of them are going to be able to have control of their disease. And I hope those showed up on time so you can answer them. It's supposed to be an interactive process.
Next question, Eileen.
Okay. Question 2, there are clinical tests for cardiac disease markers in this population. One of the things that we talked about is elevated markers can be lowered with weight loss, whole grain enriched hypocaloric diet, lower calories, statins, niacin, and omega-3 fatty acids added to the statin. So we talked about all of these issues and what they do and don't do for cardiac disease markers, which with this population is really a concern. And the answer is all of them. If you can get the person to lose the weight, especially around the middle, and you have, and that can be as easy as they're sitting in their chair and they just raise their arm up like that, just to kind of stretch out the middle a little bit. Whole grain enriched, so you have whole grains, not, you read something that has multi-grain, well, multi-grain is all well and good, but is it whole grain? If you just have a whole bunch of grains but they're all mashed up, it's not as good as whole grain. And lower calories, statins if they need them, and adding niacin and omega-3 fatty acids.
Next question, Eileen.
Question 3, seizure management in elderly DD consumers is complicated by issues of medication absorption due to frequent GI problems, often best accomplished using 2 or more anti-seizure drugs, AEDs, simultaneously, complicated by inconsistent verbal reports from consumers, and it relies on both behavioral observations and lab testing to assess the response to the anti-epileptic drugs. And the answer is complicated further by inconsistent verbal reports from the consumer, and I also should include some of the caregivers, because if you have family caregivers, they might not be as sophisticated about detecting some of these symptoms. And we really need to watch what's going on with them, and if we are able to do lab testing for their AED levels.
Next question.
Question 4, given that elderly DD consumers are likely to have significant cognitive problems, depressive impacts on cognition are easily differentiated, behavior of consumers is less influenced by praise or rewards, consumers are unlikely to be responsive to verbal interventions, and symptoms of dementia appear later and are not as recognizable as with the general population. Now, we talked about this in detail, but it's phrased in a different way. I mean, I kind of flipped it so it's 180 degrees in the other direction. So if you are answering this question as it's being asked, the correct answer is D, none of these, because depressive impacts on cognition are not easily differentiated. You really need to pull the threads to figure that out. The behavior of consumers is, of course, influenced by praise or rewards. We're all social beings. We all have a social consequence, an interaction consequence to what happens to us. Consumers are going to be responsive to verbal interventions. That works. And symptoms of dementia appear earlier, not later, and are exactly as recognizable as with the general population. So I did kind of a sneaky thing with that.
Next question.
All right, this is the last question. Physical characteristics typically associated with elderly developmentally disabled consumers are primarily congenital in nature, primarily due to medication side effects, associated with lowered resistance to communicable disease, or are associated with both congenital and medication side effects. So when you consider what we've talked about today with people who have developmental disabilities and their geriatrics and with everything that's happening to their bodies, the answer is D. It's associated with both the congenital problem of their developmental disability. That's going to determine how they're wired, what's going wrong with them, what's happening with their bodies and their brains, and the medications that they're on for their comorbidities. What's happening to them and what kind of side effects are they going to have. Because there's side effects to everything. It's just how much of a side effect the person is going to have. So that is the last poll question. And of course, if you have questions for me, you can type them in at where the hand is. And the evaluation survey should pop up when we're finished. So please fill out that survey. It's very important to me to know what's going on with this information and how we can make it better for you. And if you don't see the survey, follow the link. You'll be sent a follow-up email tomorrow, and follow that link, and there'll be a survey there. Okay.
Eileen, we do have a hand raised.
Yay!
So,
okay.
Yay! I'm going to unmute Elaine. Elaine, you can go ahead and ask your question.
I'm sorry, that was just a technical error on my part.
Okay, no question?